The first one to go is progesterone. Progesterone is, I think, in order to understand progesterone, we should talk a little bit about what happens in the normal reproductive cycle.
Yes.
When a woman is after puberty, when she's having regular menstrual periods, she will have a very predictable rise and fall of hormones throughout the month. As the egg in the ovary is being signaled to mature, estrogen levels are rising. That would be from the time of your period until about mid-cycle. At mid-cycle, ovulation should occur. And after ovulation, the small sac that the egg was growing in will turn into a little mini gland that lives for about 2 weeks, and it produces progesterone. So in the first half of the cycle, from day 1 to approximately day 14, estrogen is the dominant hormone. And in the second half of the cycle, from ovulation until the next period, progesterone is the dominant hormone. And it's the interplay between these two hormones that allows us to have that regular rhythm of the menstrual cycle. Around age 30, the production of that little mini sac that makes the progesterone becomes less likely to happen. It might not happen at all, or the little sac, which we call the corpus luteum, it doesn't last the full 2 weeks. So progesterone levels start to drop.
Hello, everyone. Welcome to the Center Table podcast featuring Miss Carolyn Hawes of FindingFifty and Kamisha and myself, Denise, of the Wisdom and Bloom podcast, as we bring to you, and we'll be bringing more of our center table as we are coming together and collabing to talk about things all important and critical to women over 40 who are going through all the things. So thank you so much, guys, for joining us today. We have Dr. Christine Hatfield, and she has been a physician for more than 30 years. She began her career in I can't say that word. Kamisha, help me out. Obstetrician
gynecologist.
Yes,
obstetrics and gynecology.
Thank you. That's it. Obstetrics and gynecology. I'm always struggling with that word. But guess what? I'm gonna edit that part out. So, or I might let it.
I know. I love editing.
Or I might let it stay in because somebody's out there going, I can't say that word either. Obstetrics and gynecology. She loves it. It's fulfilling. She realized this was a subset of women who were not managed well, especially going through perimenopause and menopause. And she learned very little about it in her OB and GYN training. So she felt the need to extend her knowledge. And so we have Dr. Christine Hatfield. She's licensed. And like I said, she's been working with women's health for over 30 years. She earned her Bachelor's of Science with honors from Acadia University. She's followed that by a degree in medicine from the University of Western Ontario in 1994. She's graduating with a prize in preventive medicine. After completing her residency in obstetrics and gynecology, she worked as a community obstetrician gynecologist for more than a decade. In 2012, she completed her fellowship in functional and anti-aging medicine throughout the University of South Florida. And following her passion of anti-aging and regenerative medicine, she went on to obtain certification in both medical laser and aesthetic injection procedures. She is a member of good standing with the Royal College of Physicians and Surgeons of Canada and the College of Physicians and Surgeons of British Columbia, the North American Menopause Society, and the Canadian Board of Aesthetic Medicine. Dr. Hatfield is a medical director of a busy anti-aging clinic in Vernon, British Columbia called EspritMD. She is an expert in bioidentical hormone therapy, pelvic floor disorders, female sexual dysfunction, and aesthetic medicine. She uses a holistic approach to guide her patients through the menopause transition, helping them to find their spark again. She currently has 4 people on her staff, including her nurse practitioner, her anesthetic nurse, and they are a team of women, all women, supporting women, for women, working with women as they are challenged through their stage of life. This is a rewarding platform for her, and we are so excited to have Dr. Christine Hatfield on our platform as we talk about all things menopause today. Welcome, 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 Dr. Hatfield.
Welcome.
I'm exhausted now, so I don't know about that's way too much. Those accolades are just incredible.
That's what happens when you're addicted to learning.
Oh, what a powerful statement. This is what happens when you're addicted to learning. Not only that, I am a fan of bios. I don't know if Carolyn, if you ever talk to Carolyn, I am a fan of bios because we work so hard to learn and to be able to share our knowledge. And most time when people come and see you, they see their tunnel vision. They see what they need from you right at that moment. They don't know that for 30 years you've been grinding to make sure that at that very moment you're giving them the right information that it took you 30 years to see them for 30 minutes. So
Yeah,
I love bios. Love it.
Yes, thank you so much, Denise. That was wonderful. That was a wonderful wonderful intro.
You're
and
welcome.
Congratulations to you, Dr. Hatfield.
Thank you.
On your wonderful accomplishments.
Yeah.
So where should we start this?
When I grow up, I'm going to be a professional introer.
I think you've gotten there, baby. You do better than I do.
Doing that. Yeah, I feel like you already are a professional introer. What else do you want to be introing?
But I follow for my tongue.
Oh my goodness. Kamisha, go ahead.
I forgot what I was going to say. Oh, no. I remember now. Yes. I was going to ask Dr. Hatfield, where is a good place to start this conversation about menopause? Should we start talking about the terminology, what is menopause versus perimenopause, or the hormones that are going to be impacted? I feel like there's so much basic information around menopause that is completely lost to women that we need to share. So I would ask you, where do you think would be a good place to start?
Sure. I think that's a really important thing to start with, because as I say all the time to my patients, no one's teaching us what's going to happen at menopause. Right? There's no course that we get when we turn 40.
Yeah.
You get some kind of education in middle school when you go through puberty, but there should be a mandatory menopause course. So I'm really glad that these platforms like podcasts exist so that we can get that information out there, because otherwise women are not getting the information they need. So let's start with some terminology. So menopause, that term gets thrown around a lot as almost the all-inclusive to cover all the things happening in the transition, but really what's happening is the woman is transitioning from being able to reproduce to being no longer able to reproduce. She has a certain number of eggs in her ovaries that she's born with, and over the many years of having menstrual periods, approximately 30 years, those eggs decline, and when the eggs are completely gone, then she is no longer able to reproduce. So that's what the whole transition is about. And it happens around age 51 that you have that last day of period. You become menopausal when you have that last period. It's something that we can only look at in retrospect. We have to look backwards and say, okay, my last period was on such and such a day. And when it's been exactly 12 months from that last period, you were considered postmenopausal. Now, in the years leading up to that, go ahead.
Ask your question. Why 12 months? What was the significance of 12 months?
I think that there is no significance. It just felt that that was the length of time that would be adequate to say this woman's unlikely to have another period. We can be sure that she's now finished that transition. But I don't know, other listeners out there who are in the medical field might know that not everybody follows by the playbook that we're given. Some women will go 12 months without a period, and then all of a sudden they have a bleed, and they're disappointed to find out they have to start counting again, that they haven't reached the menopause, final, gone through the finish line. Exactly. So the years leading up to that final period we call perimenopause. Some people might call it premenopause, but it's a roughly 5 to 10 year length of time when there's a lot of chaos going on in the hormonal milieu, if you will, that the hormones are going through big fluxes because the ovaries are slowly winding down, and they don't do it in a slow and steady way. It's very erratic. And that's why perimenopause is marked by a lot of symptoms that don't always follow any type of rhythm or pattern. And women are really confused about what's going on for them in that stage of life.
Now, what hormones are impacted during this time?
Yeah. So the main hormones that we're talking about are the ones produced by the ovaries. So there's three players. We have estrogen, progesterone, and testosterone. And each of those hormones is declining through that perimenopause transition. And some of them continue to drop even after the last menstrual period. Wow. The first one to go is progesterone. Progesterone is, I think, in order to understand progesterone, we should talk a little bit about what happens in the normal reproductive cycle.
Yes.
When a woman is after puberty, when she's having regular menstrual periods, she will have a very predictable rise and fall of hormones throughout the month. As the egg in the ovary is being signaled to mature, estrogen levels are rising. That would be from the time of your period until about mid-cycle. At mid-cycle, ovulation should occur. And after ovulation, the small sac that the egg was growing in will turn into a little mini gland that lives for about 2 weeks, and it produces progesterone. So in the first half of the cycle, from day 1 to approximately day 14, estrogen is the dominant hormone. And in the second half of the cycle, from ovulation until the next period, progesterone is the dominant hormone. And it's the interplay between these two hormones that allows us to have that regular rhythm of the menstrual cycle. Around age 30, the production of that little mini sac that makes the progesterone becomes less likely to happen. It might not happen at all, or the little sac, which we call the corpus luteum, it doesn't last the full 2 weeks. So progesterone levels start to drop roughly in our 30s. Estrogen production continues just as normal. So the interplay between those two hormones is no longer balanced. Estrogen becomes more dominant throughout the entire month because there's inadequate amounts of progesterone. And it's during that stage that women will start to notice some changes are happening. She might notice that her periods are becoming heavier. She might have cramps. She will be noticing more premenstrual symptoms, especially bloating and breast pain and cravings, sometimes headaches. Often she will feel that she's putting on water weight or even gaining weight from fat deposition. Mood changes start to show up, and commonly fatigue. So this is the early stages. I call that early perimenopause, when progesterone levels are a little too low and estrogen is doing its own thing, still normal, still cycling, but not being properly balanced. Does that make sense?
Yeah, got it.
Yeah, that does. And I'm actually learning something, because it sounds like progesterone is the one that actually kind of starts a lot of the challenges, right? I guess I always thought menopause was, well, I mean, I knew it was the three hormones, but I honestly didn't know how progesterone was really playing in there. I thought it was more estrogen than any other hormone.
Yes, and estrogen comes up a little bit later as we get into 40s and closer to 50, because now the eggs are having a lot more difficulty responding to the signals from the brain, and ovulation may not happen at all, or sometimes it happens twice in a month. So things get really mixed up and confused. But over those last 5 years before the period stop, that's when we start to see the estrogen levels declining. So this is later perimenopause. And I think of it like a woman has a gas tank that's filled with estrogen, and you can go from having a full tank of estrogen to having absolutely no estrogen in a matter of a day or two.
Oh my God.
So this goes on throughout the month. You lose that regular, nice, gentle rhythm of the estrogen that was once present. It becomes very erratic. So the estrogen levels are spiking and falling literally overnight. And this causes a lot of confusion in the body. And I just always talk about it as being hormonal chaos.
Yeah. It's interesting too, I think, A lot of women, including myself, before I started to be your patient, was the fact that testosterone plays such a major role
Mm-hmm.
in women's health.
And I
I
didn't
think,
know that, Carolyn, until we had that conversation some weeks ago, how much
mhm,
it played. Because when you think of testosterone, you just think of male dominant, that's a male dominant
absolutely.
thing. You didn't think. Yeah.
Yeah,
Yeah.
absolutely. You don't attach it to it being a hormone that women produce as well, you know.
Mm-hmm.
Yeah, I'd like to talk about testosterone, but I'll just finish up the estrogen story and then we'll move on to that one.
Sure,
So
yeah.
the estrogen level is dropping. Many of the premenstrual symptoms get exaggerated, and then we start to see some new symptoms like hot flashes and night sweats,
Mm-hmm.
vaginal dryness, urinary incontinence, skin changes, especially fine lines and decreased elasticity of the skin, starting to see those wrinkles, brain fog and poor concentration. We know estrogen is extremely important for the brain, fatigue, and just a pretty much global over like poor tolerance to stress, I find.
Yeah.
And I think it's a combination of the not sleeping and just not feeling like yourself, because
Yeah.
estrogen's been such an important part of a woman's life for 30 years and suddenly it's gone.
Yeah.
Mhm.
Yeah.
Yeah.
So that's what happens in your late 40s, early 50s. Eventually you reach, as I said earlier, you reach that final egg. The last one drops. There won't be any more. Now estrogen is low, your gas tank is empty, and it stays empty for the rest of your life unless you go on hormone replacement. And that lack of estrogen has some pretty detrimental effects on the female body. She may continue to have symptoms for a few years after that final period, hot flashes and insomnia, and maybe a little bit of brain fog. Some women recover from that and it's almost like they get used to their new normal. But for the majority of women, they have other problems that they just put up with if they don't seek help. Vaginal dryness can lead to a point where they're not able to have comfortable sex, or they might have pain and bleeding, recurrent urinary tract infections. Memory can become very severely impaired. They have joint pain. Sometimes autoimmune conditions show up at this stage. There's a lot that can go wrong when the hormones disappear.
Now, what about, I know you're talking about you're going to get to testosterone, but what about premature menopause? Does that have a play in some women? Because me and Kamisha was talking about that, where she started going through some form of that in her early 30s. And with me, I had a hysterectomy in my early 30s, and it was like my body was jolted into this cycle, like it was like an explosion.
Yeah.
So is this a thing, and is that a part of this, or could it be a part
There's been
of
a lot of, yeah, I think there's been a lot of confusion about, well, when does menopause start?
it? Mm-hmm.
And women go to seek help from their doctor and they're told, oh, you're too young,
Mm-hmm. Mm-hmm. Mm-hmm.
menopause. And they're thinking that they're too young to stop having periods because the typical age is 50. But as I said, those symptoms can start in your early 30s.
Mm-hmm.
With that decline in progesterone and also testosterone, which we'll get to in a moment. So women can start to have symptoms in their 30s, absolutely. But they may go on. It doesn't allow us to predict when that last period will be.
Right.
There is a condition called premature menopause, which is when your periods stop before the age of 40. So there's complete ovarian failure.
Mm-hmm.
And that's thought to be an autoimmune condition. So it's a little bit different, but the symptoms are exactly the same with the loss of the estrogen and the progesterone. Yeah. If a woman has a hysterectomy, she has what we call surgical menopause. She no longer has periods, but it was artificially induced upon her. If her ovaries are still functional and left in the body, they should continue to produce some hormones until she reaches a natural age when menopause would happen, which would be roughly around age 50. But there seems to be some disruption to blood flow to the ovaries in women who have hysterectomy, that they will report that their symptoms come on slightly sooner than other women, and that they need to seek help a little earlier than other women do.
Yeah. And just to hear you explain that surgical, menopause. This is the first time I'm really hearing this and hearing it explained like that. I was sharing that no one told me that when I had my hysterectomy, no one explained that to me, that that was going to happen to me. I literally thought I was going crazy. I was out of work for almost 2 months because I thought I was losing my mind. So no one ever explained that to me. So just to think at that moment, if I had have been prepared, if
Yeah.
someone explained to me this, you're going to have a hysterectomy, and this is the things that could happen. You could go into surgical menopause, and in that, these things may happen. Not all of them, but some of them, or all of them. But be prepared if they do happen. That would have taken so much. That would have brought me so much comfort, because I literally thought I was going crazy.
Well, speaking as someone who went through the training to be an obstetrician and gynecologist, we didn't get a lot of teaching around this topic. And it comes with experience when you start to notice patterns with your patients. And to be fair, not every woman will have trouble after hysterectomy,
Right.
but select women, they do. And it's important just as a physician to have the awareness that that could happen, and for women to know that can happen, so they can bring those problems back to their doctor and say, hey, could this be what's going on with me? Do I need some help here?
And are these tests that can be given? So, for example, I guess the progesterone test, to women at maybe in their 30s, if they are starting to experience some kind of early menopause symptoms, is that something that can be checked or tested?
Yeah, of course it can be tested, but the trouble with hormones is it's difficult to get them to behave. As I explained earlier, they're moving all throughout the month. So you have to be very precise about the day of the cycle that you're having the test done, and be able to interpret what that information means. If your progesterone was measured on day 4 or 5 of your cycle and it's found to be low, well, that's normal for that stage of the cycle. I would prefer to test progesterone in that luteal phase, when we know the ovary is meant to be producing it, usually around day 21. But an absolute progesterone value doesn't always tell us what's going on, because 1 month it may be good and the next month it's not. So testing can be helpful. And I do testing in my practice because I find my patients want to know what their levels are. It gives them some comfort to know if we find something that's wrong. But if their levels come back normal, I never dismiss and say, well, your levels are fine, there's nothing wrong with you. I understand that this is much more complex than just a simple blood test can tell us, and that the interplay of the hormones is important. And there may be other factors going on with her health and lifestyle that are contributing to the symptoms, and her progesterone being slightly lower than what's optimal for her might be why she has symptoms, even though her lab test says it's, quote, normal, because there's a big range for these hormones as well. So testing can be helpful, but it has to be done by someone who understands how to interpret the levels.
Right. There's a lot of nuance.
Hormones are like naughty children. They don't always.
I was going to call them bastards, but that's a much nicer way of saying it.
Okay, I don't want to forget about testosterone, because of the three, this is my favorite hormone. And the reason I love testosterone is because when it's low or not optimized in a patient, and I correct that for her, it's like all the lights just come on. I personally experienced that when testosterone was introduced to me when I went on hormone replacement. I really felt like my brain switched on, and I heard a little voice in my head say, oh, there you are. Like I had been missing for years. So testosterone, let's just get the record straight, is not a male hormone. Women make testosterone. Here's a surprising fact. Women have more testosterone in their body at every stage of life than they do estrogen.
Wow.
Yeah.
What?
It's a much more plentiful hormone. The reason that women don't look like men is because we have 10 times less testosterone than a man. So the estrogen can have more of an effect. Men also have estrogen, which might surprise some of your listeners.
Wow.
It's just that the ratios are different between the two sexes. But if you look at how many molecules of each hormone is in our body, we have much more testosterone than we do estrogen at every age of our lives. Yeah.
Mm.
And testosterone's amazing because, well, I'll tell you what happens when it's gone, then you'll understand why it's so amazing. So when testosterone levels drop, women will tell me that they have irritability. They'll notice that their motivation drops off. They have decreased confidence. They may have poor concentration and focus, mood changes, especially depression, fatigue. Then there's other physical symptoms such as urinary urgency, pain with sex, definitely vaginal dryness, night sweats, especially those night sweats that are happening in your 30s and 40s. It's not from lack of estrogen generally at that stage. It can be from the missing testosterone. And the big one, difficulty with sexual arousal and libido. So testosterone's working in an awful lot of parts of our bodies, from the brain all the way down to our vagina. It's so important. And by age 40, it's estimated that we have half of the amount of testosterone that we had in our 20s. It peaks about 25, and then it's all downhill from there. And it's
all downhill.
But unlike progesterone and estrogen, it doesn't always fall off a cliff. It's a more subtle and gradual decline. And I think for all of these hormones, we've got a sweet spot where there's a certain amount that's just right for that woman. And if it goes too high or too low, she's going to feel off.
Yeah. And one of the things that I experienced definitely when visiting you was that you listen to a woman's symptoms, you listen to how they're feeling, and there's no gaslighting with how they feel. You are taking it in, and the fact that as you're reiterating here on the podcast is that every hormone plays a role, but it plays a role or shows itself possibly a little bit differently in every woman. And so one woman will have some symptoms while another won't, or they'll have completely different ones. And some of the symptoms are ones that we have never heard of or wouldn't even expect. I mean, I'm still surprised by some of the symptoms.
Like frozen shoulder, I had never heard of that. Didn't know anything about that.
Yeah. And it's so important for women when they are feeling all of these different symptoms, not knowing what's going on. And you do start to feel like you're going a bit crazy sometimes. And the resilience isn't there anymore. As you were saying, it helps us to deal with stress when we are, when we're elevated in all of our hormones and we're at our optimum levels. And when they suddenly drop, our resilience to a lot of things just isn't there. We're not sleeping. We're not all of the normal things that we have the motivation to do. We might not have the motivation to do anymore. And it's surprisingly under identified, I guess, when women are going to their family doctor. And as you said, it might not be something that they've had a lot of time in medical school to cover. And it's, I'm not really sure where I'm getting at right now, but I just want to say that is so important that you listen to all those symptoms that women have. And I really do appreciate that.
That's where you were going. That's the impact. That was the statement you were making. Is that Dr. Hatfield actually listens to her patients to try and figure out what's really going on.
Absolutely. Yeah, you absolutely do that. I
so appreciate it. I also found it interesting too that it sounds like there's these three hormones, right? And they can impact you at different times or like all at once. They can all be kind of working on the decline all at one time, which can then, I guess, even make the symptoms even worse, right? For whatever you're going through during like this perimenopause stage. It's how I was understanding you to explain it, that progesterone kind of is what starts declining in your 30s, but then also testosterone can start declining I don't know, after 25 or so. And then you have, estrogen, making it fall off of a cliff. So there's no, it's no wonder then why women are like kind of scattered and all over the place when you have this hit, these punches kind of like 1, 2, 3 from all of these hormone levels dropping, raising, or just kind of dropping. Like, and it can happen all at once.
Yes.
That's
Yeah.
yeah.
And these aren't the only hormones that are involved either, because the endocrine
Oh.
system is really complex. It's a big web, and the impact of what's going on in one endocrine organ, like the ovary, is affecting or affected by your adrenal glands and your pancreas and your thyroid. So we can sometimes see disruption in multiple systems going on alongside the decline in the sex hormones. So just to make it all even more complex.
Well, I find that interesting that you say that, because when I was going through my premature menopause, like in my 30s, one of the things they kept testing was my thyroid. They were like, it's your thyroid. And then, my thyroid levels would be high, but then my thyroid levels would be low, and then my thyroid levels would be normal. And then they were trying to figure out, what was going on with my thyroid. It's like they kind of isolated it to just that one area. But, listening to you, there's a lot going on, right? There's a lot that's being impacted with the endocrine system in general.
It doesn't help that many of the symptoms overlap with each other as well. So I've mentioned fatigue a number of times. So that can be a symptom of low thyroid, can be a symptom of adrenal dysregulation. It can be a problem with low estrogen or low testosterone. So which one is it? So you need to be a little bit of a detective to figure out which hormone or hormones are the culprits. And that's why I don't think you can just do this in a short visit. I spend at least an hour getting to know my patients when they first come in to see me, and visits are usually, as often as I can, they're 30 minutes long, because for follow-ups, because it is so complex, and we want to make sure that everything is being optimized.
How does testosterone in the decline play into ADHD? I've had several women, including myself, say, something is happening. My focus is off. Now I have sticky notes everywhere. I sit down to do one thing, I'm doing another thing, and I can't even remember that I was supposed to be doing the first thing. And it's like, how do I get to become 50 and 60 and now I have ADHD?
Right. Okay. I'm going to preface this by saying I am not an expert in ADHD, but there definitely is a connection between the drop in both estrogen and testosterone and the presentation of ADHD. So for your listeners, ADHD is attention deficit hyperactivity disorder. It's usually marked by problems with focus, organization, memory, and sometimes emotional control. You do not need to have the hyperactivity part of it. Some people might be fidgety, but you can have just the poor focus and the brain, what we'll call brain fog. But this is usually a diagnosis that's made in children. Many women reach adulthood without a diagnosis because they're very good at being able to hide their symptoms, and they find coping skills. So a woman may have ADHD her entire life, but she found strategies to help it not be a problem. And she was good enough in school that the teachers didn't point it out, and she was able to get by. But as you said, when that hormone shift happens, something changes in the brain. And we think it probably has to do with dopamine, which is one of the neurotransmitters that is involved with focus and motivation and collectively what we call the executive functioning of the brain, being able to plan and organize and multitask, those sorts of things. Estrogen and testosterone are both involved in dopamine regulation. So when those hormones drop, dopamine also seems to fall, and that's when the symptoms can appear. I also see clinically that other dopamine-related problems sometimes get worse around menopause. We see things like shopping addictions, food cravings, alcohol use. Those dopamines are reward neurotransmitter. And if your dopamine is low, you may engage in activities to try to boost it
Right.
up. Yeah. So I think there's a connection there with the hormones and the dopamine going on. So then the ADHD portion of things is just not being able to focus. If you replace the hormones, often the ADHD symptoms go away. So it can either be unmasked during menopause, meaning I didn't know I had this until now suddenly I have ADHD, what's going on? Or a woman who did know she had ADHD will suddenly get worse with menopause. But if the hormones are replaced, and hopefully we'll get to talk about hormone replacement and how we do that, she should expect that her focus comes back and she's got that clear thinking and can do the multitasking that she once was able to do with ease.
And so now that you've gatewayed us into hormone replacement, talk to us a little bit about that, Dr. Hatfield. Like, what are the current options? And I know you wrote something, you said not one size fits all. And
That's
so
right.
I would love to dig into that a little bit and also talk about it too from Black women's standpoint and from people of color and other women of non-color. Like how does that transition, or how does that flow with them? Because I know, especially for our culture, there are so many myths around HRT, and a lot of our women will not do it. They won't do it. Like, I look for natural, items to help me, where Kamisha actually did HRT. So I know that there's a lot of myths around it. So can you just kind of talk to us about that first?
Sure. Okay. So the myths around HRT have been unfortunately perpetuated for several decades. And I think it's time that we sort of dispel a lot of those preconceived ideas that HRT is somehow dangerous.
Mm-hmm.
And I don't want to go into too much detail about or criticism of research that's been done, but there was a monumental study in the late 1990s called the Women's Health Initiative that set out to show that estrogen replacement was beneficial for prevention of heart disease. They had very good intentions, but unfortunately, due to some study design problems and misinterpretation of the data, they actually did a lot of harm, because it was a stop the presses type of an event when they saw a slight increase in the number of breast cancer cases in the women being treated with estrogen and progestins. And they said, we need to stop this study right now. We're causing harm to these women. And everyone around the world heard the news, and women were taken off of their HRT. And it's estimated that millions of women suffered because of this and probably died earlier than expected, had a poorer quality of life because they were denied HRT. And that's where all of this fear comes from. And these myths just keep passed along as if it's the truth. And when that happened, I was early in my training. I had finished my residency when that announcement was made. So I kind of got away. I was familiar with doing hormone replacement. I had some very good teachers who had me think about it in a different way. So I think I was not as swayed by the results of the Women's Health Initiative and continued to prescribe HRT for patients even after all that mess went down. But that's not true for most people in my generation, and certainly not true for doctors who came after me. No one was prescribing HRT.
Yeah.
And doctors were telling their patients, don't use it. It causes cancer, or it causes blood clots, or it causes heart disease. So it just became part of the almost like the knowledge everyone knows. Oh, don't use HRT. Don't you know that it's dangerous for you? Now let's talk about what we know today.
Yeah.
That the trial was not designed in a way that could really show us what we wanted to know, because many of the participants were older women who already had pre-existing health problems. Many of them were overweight and smokers. But if you break it down into the women who were in their 50s, who were given HRT, what they've found is that overwhelmingly those women had a better quality of life and a 30% reduction in all-cause mortality. That means less likely to die from other conditions, from any medical condition, compared to the women who were in the placebo group.
Wow.
Hormone replacement is very beneficial because it's quite protective to essentially every organ in our bodies. And I can go into more detail about statistics and information about breast cancer, whatever you think you'd like your listeners.
I would love to hear it. I would love to.
Well, I have a question about how long should you take this hormone replacement? And then also the different hormones that you're replacing, right?
Yeah.
Because there's
my cheeky answer is, how long do you want to feel good? When I ask that in the clinic. But the real answer is, you can safely take these hormones. At this point in my career, I say you can take these hormones for the rest of your life. The only time I would ever take a woman off of HRT is if she develops an estrogen sensitive breast cancer. And even then, I'm hesitant to do it because I'm not convinced that the HRT is going to make her cancer come back. It depends on the stage of the cancer, but that's a much more complex situation. But for the average woman who's on HRT because she doesn't want to be bothered with the menopause symptoms and she's using it to help protect her body from other diseases that happen as we age, I say stay on that for as long as you possibly can, because the minute you stop, your body will start to go into a deficiency state and your tissues will break down and you'll have symptoms. You'll have vaginal dryness, you'll have urinary tract infections, bone loss will happen quickly. Your brain won't be functioning the way it was meant to. So I think women should stay on their hormones forever. I plan to stay on them forever.
I do too. Now I do too.
That's good.
And Carolyn, you're on them too, right?
Correct. I am.
So for both of you, Kamisha and Carolyn, what were some of the symptoms that decreased when you started HRT? What became better for you?
Do you want to go first, Carolyn?
Sure. I'll just go. The first thing that I noticed was the pain I was feeling in my joints. I was feeling all kinds of things when I would get up in the morning, to just reaching for things. It was so not typical for me, and I was still quite active and going to the gym and doing stuff, and I felt like I was breaking down, and it slowed me down quite a bit. The other part of that too was my sleep. My sleep was being highly affected. And I think those were the two things that for me, I was highly impacted by. I realize now that there was a whole lot of stuff going on at the same time. But for me, those stood out. And the fatigue I was feeling because I wasn't sleeping, and then not being able to function the way I'd always functioned because I just hurt all the time, made me less active, made me just start doing less. So it became a domino effect, and it just started going down from there. And then other symptoms were arising, but they're also intertwined. They're also heavily intertwined. Anxiety and depression was peaking, and all of it's so layered. Yeah, and connected. What about you, Kamisha?
Well, it's funny you say joint pain, because I don't think I knew that was my menopause, my early menopause was causing this joint pain. But I was having joint pain actually, and I remember this vividly because my aunt, she likes to order different vitamins and stuff from TV. And so she says, "Oh, I got this glucosamine and chondroitin, and this is going to help you with your joint pain." And so I did start taking these vitamins, but they didn't help. They really didn't help. But now I see maybe it was because it wasn't just that. But for me, one of the biggest things was fatigue. I was tired all the time, like exhausted, whereas before I could go, I have two children. They were young at the time, so go to work, take my kids to work, my husband picks them up, I come home, I do all the things, I'm still up or whatever. I would come home and I would be out for the rest of the night. Like I was out. I just had no energy for anything.
Yeah.
And I think that, as you're saying, kind of leads to other things. Then I would just become kind of sad and down and like not motivated, but not really know where that was coming from. Right. So then that's kind of like a spiral, like, well, why am I feeling like this?
Yeah.
But yeah, for me, the fatigue was really, really bad, like really bad. And now, so what I was told, Dr. Hatfield, was to take the HRT until I started getting to an age where I would have gone through menopause. So I stopped taking it around, what am I, 51? Maybe like 49? Just recently. So I took it for like 10 years because I went through menopause at 39. So I took it for 10 years. And I have noticed in the last year, especially, more brain fog, like more confusion. Sometimes I can't really express my thoughts. Like I know what I want to say, but I'm not sure. And I get confused. And I've noticed that my bad cholesterol has risen when I've never had any issues with cholesterol like before. And I was reading that could also be, a challenge in postmenopause as well. Wow. But those were the fatigue was the really the main thing. And then some of the, I guess, like sadness and low motivation or whatever that led to.
I'd love to make a comment there, which would be the advice that your physician gave you to stop around the age of menopause is, again, a fear-based recommendation. And there have been guidelines set out by various colleges of physicians and so on that were felt that they needed to be placed there because somehow hormone replacement was something that was dangerous to women. And so for a while it was, don't use hormones at all. Then, all right, fine. If you need to use hormones, you can, but use the lowest dose for the shortest amount of time period. And then they changed and said, okay, fine, you can use the hormones, but not for more than 10 years. And that's kind of where we are now with the guidelines. But the thing with the guidelines is that they're fear-based and they're ultra conservative. And I just always ask, what is everyone so afraid of? Okay, so they're afraid that somehow women are going to have blood clots. Have we seen a huge number of women dying from blood clots on HRT? No, we haven't. Are they afraid that women are going to suddenly develop heart disease? Well, the data clearly shows that estrogen is protective to the heart. Right. It keeps your blood pressure low. Just like you pointed out, Kamisha, when you don't have estrogen, your cholesterol, your lipid profile changes.
Wow.
And you lose the protective benefits of the estrogen on how the liver is producing cholesterol. When you don't have estrogen, your bones are no longer being remodeled to make new bone and they become more brittle. There's fibers within the bone that are very elastic that allow your bone to have flexibility. If you don't have flexible bones and you fall over, they're going to snap. So estrogen is very important, as is testosterone, for constant new remodeling of bone. We know that estrogen is extremely protective to the brain. And when estrogen is taken away, we see the development of Alzheimer's plaques. You're familiar with the plaques that are seen in that disease. There's less blood flow to the brain. Sometimes small strokes can happen in the brain. We have this condition called multi-infarct dementia. Who gets dementia more? It's women, not men, and because of lack of that protective effect of the estrogen. And finally, the genitourinary issues. I'm talking about all the vaginal discomfort, infections, the urinary tract infections. Women in their 80s often die from urinary sepsis, which is tragic, and it's completely preventable with estrogen replacement, whether it's total body estrogen replacement or we're just using some estrogen around the vagina to protect those tissues. At the very minimum, that's what we should be using. So I really wonder what everyone's so afraid of. And I think that it's just been this perpetuation of these myths that somehow this is dangerous for us when we have all the evidence that it's protective. And even the Women's Health Initiative said in the group that was treated with estrogen, beginning in their 50s, compared to placebo, they had a reduction in all-cause mortality of 30%. There's no other drug that does that. I've been a
No,
doctor
there isn't.
for a long time. There's no other drug on the market that can make that claim. It's crazy that everyone's so afraid of hormone replacement. So I never tell women to stop when they reach the age of natural menopause. Why would you want to? That's when I'm putting most people on HRT.
Yeah.
When they get to the age of natural menopause. And
Yeah,
I'm
I mean, that
telling
makes
them,
sense. Yeah,
I'm
that makes
telling
sense.
them to stay on it.
Mhm.
Do we want to talk about the different types of HRT and what your options are?
I do, because I heard you say something when you was explaining HRT. You said something about vaginal hormone treatment.
Yes.
So I wanted to ask, was there different HRT? Because I heard you say that. And then, is it right for everyone? Should everyone take it? Is this something that's right for everyone?
Well, let's start with hormone replacement therapy. Well, for true replacement therapy, we're putting back the missing hormones. And the goal is to bring them back to levels that you had before you went through menopause. Now, I don't necessarily want you to have periods again, although in a small percentage of people that unfortunately is hard to avoid because the uterus responds to the hormones. So some women unfortunately get a little bit of bleeding that they're not happy about. But the goal is to get those hormones back so that you're not having symptoms and we have them high enough that they're providing all of those protective benefits that I told you about.
Got it.
So there's the term bioidentical hormones, which became a buzz term in the 90s and early 2000s to differentiate from synthetic or non-human forms of these hormones that were somehow deemed to be worse for us. Let's use bioidentical. Words like natural, plant-based, all got used to somehow spin them as being, quote, better. Most of the hormones that are prescribed today that you can get from any doctor are bioidentical. What it means is that the molecules that make up the hormones are identical to what the woman's body would have been able to make on her own, to differentiate, say, from the synthetic hormones that are found in oral contraceptives or the compound Premarin or conjugated estrogens, which are extracts from horses' urine. Premarin works very well for hot flashes. It's just not identical to the estrogen that your body is accustomed to making. We have compounds now that are identical. So we can take those as oral pills, patches that you wear on the skin, gels that you massage into your skin, creams that are compounded by a specialty pharmacy. There's also pellets now that go under the skin. These are all the different options that a woman has to receive estradiol, bioidentical, human identical estradiol. And that's usually what I'm prescribing. Although the other versions are still available, I don't see any point to use them when we have these options available to us. Progesterone is most commonly prescribed as a micronized progesterone. It goes by the trade name Prometrium. I'll often have it compounded so I can make it into a slow release form. I find that works a little bit better for the sleep because women love progesterone. It helps them to sleep. They take it at bedtime. I like that sustained release. It can also be given vaginally. And finally, testosterone, which is the least understood in the medical community and the least likely to be prescribed unless you're working with someone like me who's done extra training in menopause. There's no formula of testosterone that is made by a pharmaceutical company that's specifically approved for women, except in Australia, where they have a testosterone patch for women. It's not been approved in the US or Canada. So what we're left with is either we have a specialty pharmacy compound it for us into a cream that's rubbed into the skin, or we use testosterone preparations that were intended for men, but we give 1/10 of the dose, or we have the pellets that go underneath the skin that are specifically designed for replacement of testosterone. So what I've just described are formulas that are used to replace all of the hormones in the body. I call that systemic replacement. And that's when someone says she's on HRT, that's usually what she's talking about. taking estrogen with progesterone if she has a uterus. If she has no uterus, the progesterone becomes optional, but it's very good for supporting sleep. And then if you're working with a doctor who believes in and understands the importance of testosterone, then that will be offered to you as well. Vaginal treatments are specifically for localized problems, the vaginal dryness, pain, urinary tract infections. And these are inserts that go in the vagina. There's small tablets or suppositories. There's a ring, and there's also creams. Different ways to deliver estrogen and sometimes testosterone to the vaginal tissues to reverse the condition that we call genitourinary syndrome of menopause. And some women choose to only treat that because that's the thing they're most bothered by, and they're either still listening to the fear-based comments about systemic HRT, or in women who have had breast cancer and are reluctant to use HRT, it is safe for them to use the vaginal hormones because the dosing is so low that very little of that is absorbed and goes to the breast. Some of it is absorbed. I hear some people talking and saying, oh, vaginal hormones are safe, they're not absorbed. No, that's not true. If I give you estrogen in your vagina and I give you enough of it, it's absorbed. You'll feel it. Your breast will get sore. But the dosing that's prescribed to treat just those vaginal and bladder problems is so low that there's not enough absorbed that's going to be considered problematic. So it's very safe for women to use after they've been diagnosed and treated for breast cancer.
And interestingly enough, with the fear that happens around, especially with estrogen and HRT, when we do a comparative to what we give young women with birth control pills, really, isn't this more like microdosing what we're giving women?
It certainly is. And compared to what you experience when you're pregnant.
Wow.
Right. Yeah. Yes, exactly. Yeah.
The difference is these are hormones in an older body. And I think that's where some of the concern has come from. And an older body is not the same as a 25-year-old body. And
Tell me.
But in my experience,
amen.
in my experience, if you give those hormones to a woman when she transitions through menopause, and I don't even wait until her periods stop. Let's just set the record straight here.
Yeah.
I treat women when they're having symptoms in their 40s and early 50s before the periods stop. I think there's a role to getting those hormones optimized so she doesn't need to go through all the suffering. You can really delay the appearance of aging both internally and externally and continue to feel possibly better than you did in your 30s because you're not having periods anymore, hopefully, and you're not having PMS because you're just on a steady state. You're just in a nice steady state where everything's the same every day, and it's fantastic.
Yeah.
So
can a woman, sorry, go ahead.
No, go ahead, Carolyn.
I just quickly was going to ask, can a woman start them at any time in their life too? If you haven't been taking them and you're suddenly in your mid 60s and you're deciding.
There's a few more concerns if someone has been untreated for 10 years or if she's over 60. These are in the guidelines. And as I said, the guidelines are there. I think guidelines are important, but they're not rules, they're guidelines. What we are concerned about is if a woman has gone more than 10 years without HRT and she's completed the menopause transition, could she have underlying cardiovascular disease? Could her lipids have become abnormal and she has plaque formation? And if she started on HRT, will it somehow disrupt that plaque or cause her blood to be stickier and cause a little clot to form that may precipitate either a stroke or a heart attack? So that's the concern. So what I do with my patients over 60 is I take a really good history from them. I ask about their lifestyle. I want to know how many risk factors for cardiovascular disease do they have. We check their lipids, we check their blood pressure. I ask about smoking, family history. And if I think someone's at a higher risk, then I'll have her complete more testing or send her to a specialist. I'm lucky. My husband is an internal medicine specialist, and I can just send them to him, and he'll have the conversation and do extra testing to check and see if their heart is showing any signs of plaque formation. Once I get the all clear from him, then it's safe to start the HRT. But I would say for the majority,
what test do you use to
I
see
think,
if there's any
well,
plaque?
he might put them on a treadmill and have them walk, and it's called a stress test to see if there's any changes to their cardiogram produced by the exercise. And he might send them for something called a CT angiogram, which is where dye is injected into the vein, and then the radiologist looks at the flow of the dye through the vessels in the heart. And if it looks normal, then we're happy. If it's abnormal, well, then he takes care of that problem.
Yeah. Perfect. Perfect.
But if she's healthy and I'm not noticing that she has many risk factors, I tell her these are the potential concerns, but here are the benefits that this HRT is going to provide to you. And it's a calculated risk. I remind my patients that each and every day, we all take calculated risks that we don't think much about. I got to work today by driving in my car. That's a calculated risk. There's always a chance that I could be in an accident. But in my mind, the benefit of driving to work over walking outweighs that risk. And that's how I try to explain it to my patients. I think the benefits of the HRT are far greater than the potential risk that you're going to have a cardiac event. And so how do you feel about that? And women make good decisions when they're given the information. I think the wrong thing to do is to just say, no, you can't have HRT. That's not for you. I'm not giving it to you. That's a very paternalistic way of practicing medicine. It is the way medicine has been practiced for hundreds of years. And it's not really fair. Women want the information, they want to make the decisions for their bodies. And I think as long as we're providing them information that's truthful, they're going to make the decision that they feel most comfortable with.
Yeah. So in that instance, so Dr. Hatfield, when you said if they're over 60 and they have some pre-existing or underlying condition, especially cardiology wise, would that be in the realm of, is HRT good for everyone? Is it right for everyone?
That's a good segue into that. So as I said, we have evidence that it's great to manage the symptoms of menopause. There's nothing that fixes hot flashes better than estrogen. There's no natural product. We have other drugs that are sometimes prescribed if a patient doesn't want to use estrogen or is told that she shouldn't. But nothing works as well. So if you're looking to manage the symptoms, then I say, yes, it's right for that purpose. But we have to do basically a risk assessment. And that involves going through their medical history, looking for risk factors for other diseases, ensuring that there's no contraindications to starting the hormones. For example, someone who's still having irregular bleeding or has gone 12 months with no bleeding and suddenly is now bleeding, I wouldn't start her on HRT until we figured out, does she have an underlying cancer in her uterus? I also want to know about their breast health. Breasts and estrogen, that whole conversation is extremely complicated, but I'm not going to start someone on estrogen if she has a lump in her breast that hasn't been diagnosed. So in those situations, I say it's not right for everyone until we determine that there's no reason to withhold it. But if a woman is generally healthy and doesn't have any of these underlying conditions and is wanting to be proactive for her health, I would say absolutely. It doesn't matter your race, your age. I think HRT is appropriate for everyone, but it's very nuanced. So it's not fair to say, yes, it's a blanket statement, it's right for everyone, because there will always be some outliers. But I think your doctor needs to sit with you and go through all of the potential risks and benefits and then help make that decision.
And some doctors are not versed on it and don't know how to prescribe it.
And it's not their fault. They were unfortunately raised in a time when HRT was taboo. And it's taken 30 years for HRT to suddenly become a topic that's being discussed. I've coined this, I shouldn't say I've coined this term. I came up with the term the Menaissance. I haven't heard anyone else ever say it.
Oh, I love that.
Any kind of menopause talk. But I think we're finding ourselves in the Menaissance.
Yeah.
It's having a revival, and it's wonderful. And because of that, young doctors will hopefully be trained in HRT so that in 30 years, we're not having the same conversation.
Yeah. And how important is it, Dr. Hatfield, as we're having this conversation, though, to protect ourselves from providers who are not practicing good medicine and who are giving us wrong information concerning menopause and all the things that goes in with menopause?
Well, I think women too. Yeah, women, the resources are there, podcasts, online information, books that have been written. Women can get the information and go into their doctor prepared to have a conversation, but they should also be prepared that their doctor may say, nope, I don't want to talk to you about this, because unfortunately, some doctors do have the attitude that they know best, and we're trained that way. I forgive them. I can't the system as well.
I don't, but that's good.
Come out of medical training and not have a little bit of
arrogance
and a little bit of an ego that you know what you're doing, right? That's what you were trained to do, and you don't want someone to come in and say, "Well, I read on the internet," but now the information is getting out there, and I think that women need to have the conversations. And if their doctor is not agreeable, then look for more help. There are those like myself who specialize in menopause, and there's other places they can go. What I'm concerned about is the pop-up menopause clinics that I'm seeing on the internet. I'm a little bit concerned because of an experience one of my patients had, where she simply submitted a form online, did not speak to a human. Everything was done through texting, and suddenly she was mailed a prescription for HRT.
Wow.
This is a major Canadian company that's advertised on social media and on TV that she contacted, and I was shocked when she told me that. Thankfully, she didn't continue, but there was no follow-up for her. I don't understand how that can be allowed, and why Health Canada isn't coming in on these companies. I'm also concerned about non-physicians who are making recommendations. I think you want to get your information from a reputable source. That's very
absolutely. Or some renowned books. I mean, Estrogen Matters.
Fantastic book.
Being one of them, but there are so many resources out there. The New Menopause by Dr. Haver. Yeah.
I read both of those books, and I have them in my office, and I do recommend women to read them. Another good one is, I'm just scrolling down here because I wrote it down. Oh, now I've forgotten where I put it. I think it's called Menopause in the Brain. That might not be what.
Mosconi, Dr. Lisa Mosconi. Yeah. A fabulous researcher, incredible researcher, heading up in Cornell Women's. Well, she was. I think she's just been given another huge
estrogen on the brain.
Yeah.
Seeing that when we go through perimenopause, the number of receptors in the brain for estrogen goes up.
Yes.
The brain is hungry for estrogen. Is looking for the estrogen, and if you don't provide it, well, we know what the outcome is. It's brain fog and dementia. So our brain is telling us, yes, we need estrogen.
Well,
that was astounding to me.
Yeah, what you're saying it goes back to something that we've said in one of our previous menopause episodes, which was telling women to be their own advocate, right? Don't just listen to what, you're being told, especially if you feel that what you're being told is not helpful to you. That you can continue to do your own research. Like you said, there's great doctors out here like yourself. There's wonderful books out here. And also I think the pop-up clinics speak to women's desperation, right? There's so many women that are just desperate for some support, some solution. And if someone comes along with some easy, just call me and I'll take care of all of your problems, then they are open to listening to these kind of charlatans or whatever they are out here pushing. But I think some of that speaks more to just women wanting help and not knowing where to find it. But I think
Yeah.
it's our body, right? And it's up to us to take on this task of finding out what's going on, right?
Yeah.
And making sure that we are working with reputable people to help us solve what's happening. Not that it's a problem, it's just a cycle, right? It's a life cycle. But figure
I
out
think
what's
we have to be
going on.
careful not to over medicalize it either.
Yeah.
But there needs to be more. We just need more doctors who are versed in menopause to be able to take care of the millions of women who are going through this stage of life.
Yeah.
What, Dr. Hatfield, you had one topic you were wanting to speak on is the lifestyle measures and treatments that we should be performing alongside hormone treatment. Not just doing hormone treatment to improve our life, because that's the inside, but what are some other things we should be doing?
Yeah. So there's obviously some common sense things that we should be doing. We should be eating properly. We should be trying to maintain our bodies at a normal weight. We want to not be smoking, try to reduce stress as much as possible. And though I talk about these things with my patients at most visits, and I think they sometimes get a little tired of me mentioning how important they are, but they are. But even beyond that, there's some very actionable strategies that you can do that are going to help you have a better quality of life and possibly improve your health span. Now, your lifespan is how long you will live, how many years you will live, but your health span is the number of years that you will be in good health. And the definition of good health is really personal. And what do you want to be able to do as you age? Dr. Peter Attia talks about this all the time. He talks about this in his book. I'm stealing from him, but he makes a very good point, which is what do you want to be able to do when you're 90? And if you have goals of being able to carry your own groceries, maybe get up and down out of a chair, maybe pick up your great grandchild, you can't just assume that you're going to be able to do all those things just because you're taking HRT. It requires a little bit of work, and like our bodies are like an old car. You have to put some maintenance in and get your brakes checked and change your fluids every now and then, or it's not going to run the way it's meant to. So the things I talk about the most with patients is eating the right types of food. We want to eat a balanced diet. Don't eat any fad diet. Don't go on a strange diet where you're restricting certain food groups unless you have a proven sensitivity. Eat a variety of foods, and the focus should be on leafy greens, fiber, and protein. And of the three, protein is the one I talk about the most because we naturally lose muscle as we age. HRT is great at preserving muscle on the body. There's receptors for estrogen all over our muscles. Protein intake needs to be higher to prevent the muscle from breaking down. We call that in medicine sarcopenia. We don't want that to happen. So our requirements for protein are higher as we get older. And what do women do? They eat less as they get older because they're trying to not be overweight. Well, we need to eat more protein because it not only gives us more lean muscle, but it helps us with our appetite. So your protein requirements should be roughly 1 gram per pound. So if you weigh 140 pounds, 140 grams of protein per day. That's not easy to do unless you're paying attention. You have to track it and eat extra protein. So I make sure I have protein at every meal, and I try to have one snack in the day that's just pure protein.
An example. Give us a meal example and a protein snack example.
Sure. So for breakfast, Greek yogurt is a favorite of mine because I'm not sensitive to dairy. That's okay for me. So I'll have enough Greek yogurt. So I'm getting about 20 to 25 grams of protein. I usually add some nuts to that and then berries for the fiber. And that's a pretty good breakfast. At lunchtime, it's usually some type of leftovers, meat or chicken with vegetables, usually what I'm having. Or sometimes I'll make a salad and put a piece of protein about the size of my palm on there, because that's roughly 20 to 25 grams. And then I'll have another meal at dinner time, similar. And then somewhere in the day, I'll usually do a whey protein shake, and that's going to be roughly 30 grams. I'm working hard to try and get my 120 grams in. I don't even know if I can get 140. Luckily, I don't have to eat that much. You have to eat a lot to get that protein in. Hard-boiled eggs are a great source. Really, any type of lean chicken, meat, fish, excellent. And in addition to that, we need to be doing resistance training. When we exercise our muscles and we're doing resistance or strength training, we're telling the muscles, I want you to be stronger and I want you to grow. And if your muscles are strong and growing, then you're going to have better balance. You're less likely to fall in later years. You'll be able to carry your groceries. You'll be able to put your suitcase in the overhead compartment without any help. It's all about staying strong. Dr. Stacy Sims has a great podcast, and she has a wonderful website, and she is a real advocate for educating women about the importance of exercise. And I would encourage your listeners to look up her work. She's someone that I follow. There are some supplements that I recommend people take. Don't want to take too many supplements, and it's not to replace anything in your diet. Supplements means you're supplementing, you're just helping along. I think the most important ones would be vitamin D, the B complex, magnesium. I put everyone on magnesium. They take it at bedtime. It helps them with their sleep. If they're missing iron because they've had a lot of heavy periods, we make sure we get that replaced as well. That often corrects the fatigue that many perimenopausal women are experiencing, because it's not just the hormone loss, they're anemic as well. 5-HTP and L-theanine are great for boosting mood and for sleep support, and I'll do that alongside of HRT.
What's the name of it again, Dr. Hatfield?
5-HTP and L-theanine. So the first one is a precursor that helps your body to make serotonin and melatonin. And the second, L-theanine, is a calming compound that comes from green tea, but it's not stimulating because there's no caffeine. The L-theanine hits the GABA receptor in the brain and can really help with sleep.
Spell that for me, Dr. Hatfield.
THEANINE. And then one of my favorite supplements is creatine. And creatine is really important for your muscles. It helps replace some of the phosphate that's lost when we exercise. So phosphate is needed for our bodies to make ATP, which is, think of the little batteries that all of our cells are running on. And after exercise, we need to replenish that ATP, and our body requires phosphate to do that. So creatine phosphate is where the body can get those phosphate molecules from. It's wonderful for not only muscle recovery, but also for bone. And now they're starting to show that it's beneficial for cognitive health. So the dose is between 5 and 10 grams a day. It's a powder. I mix it in with my protein shake, and I have that.
And what was the name of that again?
Creatine, CREATINE.
I got it.
Now you can get these over the counter. These don't
my
need to
husband
be
takes
prescribed.
Yeah, they're all over the counter.
Costco. I take mine in my Greek yogurt.
This is very good.
Yes, it disappears. You don't even know that you're taking it. Creatine really has no taste.
Wow.
Okay, so pelvic floor treatments, and then the GLP-1.
Oh yes. Well, pelvic floor. I'm a gynecologist, so I've a history of doing a lot of pelvic floor surgery when I was doing that kind of practice and treating women for incontinence using surgical options. When I stopped doing that to focus on menopause care, I no longer had a solution for helping women with their incontinence. So I was searching for what else can I do, and came across some wonderful technologies that can be quite beneficial. So one of them is vaginal laser rejuvenation. This uses an erbium laser in the vagina to increase collagen and elastin production. around the vaginal walls. Your bladder and your vagina are very closely connected, one sitting on top of the other. Vagina, or your bladder sitting on top of your vagina. And when that tissue becomes weakened, the bladder sags and falls, and that can contribute to urinary incontinence. Also, vaginal laxity, which interferes with pleasure during sex. So patients will have a series of vaginal laser procedures or treatments done in the clinic. And what they tell me is that their incontinence improves, their sexual sensation improves, they no longer feel that pelvic heaviness that they once did. So that's a treatment that's really helpful. And more recently, I've brought in a device called Emsella, and this is a chair with a large magnet in the seat. And while you're on the Emsella chair, it is sending powerful waves of energy into the muscles of the pelvic floor. And it does the strongest Kegel that you've ever experienced. And it does it repeatedly for 30 minutes, pulsing on and off.
Can we smoke a cigarette when we're done?
No, it's not orgasmic, but it helps with orgasm strength later on because it's conditioning of the pelvic floor. So I, for years, send patients to see the pelvic floor physio, and kudos to them. They do good work. But the problem is human beings are lazy. And when they're given a series of exercises to do, they will do them. They'll be very committed for about a week or two, and then they stop. And so pelvic floor exercises will not help you if you don't do them.
Or if you can't feel it.
Or if you can't feel it, that's right, Carolyn.
You can't even feel that you're engaging those muscles anymore because you just have to have that sensation.
I have one patient who just told me yesterday that she does her pelvic floor exercises faithfully and she's not seeing any improvement. I examined her. I said, okay, give me your best Kegel. I could barely tell that she was doing it. So she's not engaging the muscles. So what the Emsella can do is not only strengthen the muscle, but it can teach you what it feels like to engage that muscle so that you can do it on your own. So that's another great tool that I have for assisting women who have incontinence.
I remember back in the day, the Kegel balls. Does anybody remember that?
Still around. They're still around. I still talk to women about them. They're weights that you have to train yourself to hold in place. But again, humans are lazy, and if they can find a better way to do it, that's not going to be as much work. They'd rather take that as a general rule. I shouldn't make generalizations. That's pretty typical. GLP-1 agonists. These are the medications that go by the name of Ozempic, or Wegovy, or Mounjaro. I use them in my practice because weight loss is hard.
Yeah.
And menopause is not fair to the female body. And if you haven't had your hormones balanced throughout your perimenopause, there's a good chance that you've put on some weight that's going to be a challenge to get off. Once she's balanced with her other hormones, I think small doses of these GLP-1 agonists are perfect to just get that little extra off. Now, some women do enter menopause already with weight problems, and this is a different kind of issue, but I'm talking about the women who put on, those pesky 15 to 20 pounds that they just can't seem to shed.
32.
What was that?
That pesky 32 pounds.
Pesky 32.
Well, whatever your pesky weight is, often a GLP-1 agonist with all of the nutritional things I've talked about and engaging in resistance training can reverse that so that you're back to your premenopause weight, your happy weight.
Yeah.
And it's nice to be able to gift that to my patients because they want to feel good. They want to feel sexy. They're at a stage of their lives where they're more independent. They no longer have, for most women, their children are grown. Maybe they have a good job. They have money. They want to travel. They want to look and feel their best. And the weight can be hard to lose. So they're
rediscovering their prime too, right?
Yeah, Carolyn.
Yeah. And as we talk about estrogen, when we said that there are all the benefits of it, there are risks, but there are all so many more benefits that outweigh them. Excuse me. When you're at an ideal weight, there's so many less risks to, there's diabetes, there's heart issues, there's so many different things. So why not offer women something that can make us feel better, to move more freely, feel better in just when we're moving and where we're going and what we're doing. Excuse me. And also lessen some of those other risks that do become higher at these age groups for us.
And risk to your joints, because carrying around extra weight is I agree completely, and I'm not opposed to prescribing them. I hear concern from patients that they've read that, this is going to cause me to lose muscle. And I explained that it's not the GLP-1 itself that causes you to lose muscle. The GLP-1 is it's a peptide that our body makes naturally. It exists in the digestive tract. I think of it more like HRT. I'm just supplementing back something that your body doesn't seem to be making enough of, which is why you have cravings for food, why you have developed insulin resistance, why you find it so hard to stop eating when food is in front of you. What happens when we take these medications, which are analogs of the peptides that we naturally make? Appetite is naturally reduced. The movement of food through the gut slows down, so you stay full longer. And the centers in the brain where dopamine's active, where cravings come from, quiet down and food chatter goes away. Some of these patients have told me, like, I can't believe that I'm no longer thinking about food, where I was thinking about food all the time and constantly nibbling and constantly this and having a little of that and finishing their plate in a restaurant when they really weren't that hungry. Now they can push it away and the weight comes off slowly. The GLP-1 agonist does nothing to your muscle directly. The problem arises if the dose is so high that you become anorexic, you don't feel like eating anything, then you'll lose weight very quickly and your body doesn't differentiate. You'll lose fat and you'll lose muscle.
Right.
So the goal is to lose the weight while maintaining the muscle. So I encourage them, eat your protein and do your resistance training. We're going to offset that potential for the body to lose the muscle and just shed the fat that you don't want.
Well, to just chime in on the chatter part, I have a joke that me and my husband always, between me and my husband, and I'll tell him all the time because I'm always hearing the chatter. And I tell him my two inner fat girls are always talking and they're arguing inside of me. One is saying, come on, we do not need that cookie at 10 p.m. And the other girl is like, girl, you could do it. Just eat the cookie and don't eat breakfast. But, and I say that funny, and that's like a little funny joke in our house. My husband says, your inner fat girl hungry today, but it truly is chatter. Like my brain won't stop thinking about the food or the next meal, or I get hungry faster, or I'll skip breakfast because I think that's what I should do, and then just eat lunch, but then I'm hungrier even more later.
Yes.
It's just like this vicious cycle. And then I suffer from PTSD. So triggers makes me want to reach for food. And it's just my inner fat girls are having complete conversations all the time.
Yeah. And as we mentioned, or as Dr. Hatfield mentioned earlier too, like in these mid ages that as we start going through perimenopause and menopause, the difference in how we're feeling and the depression or the anxiety, and to get any dopamine is just almost like a clinging to some life, you know. And some might find it with food, like I find it with donuts.
I find it with food.
But you know, we're there, it's so layered with other things. It's not just simply that, you know, we're always wanting to eat. It's also our brain talking to us on different levels and saying, you know,
I need something.
I need something. Yeah.
What
I need to feel better.
Yeah, and what I love about this, though, Dr. Hatfield, is that you're not just treating menopause symptoms. You're treating the person, the patient. Like you're seeing the whole person holistically. You're seeing everything. Okay, it's not just about HRT. You know, how's your intimacy going? How is your vaginal health going? How is your exercise going? How are you sleeping okay? Like, you're treating the entirety of what's going on with that person. I love that, because you just didn't hone in and say, okay, this is the thing that's wrong with you. We'll give you HRT and then that will fix everything. And it won't. It's just not it's
There's
there's
no
a
magic.
whole realm of things. There's the
Yeah.
entire package. And so you see the patient and you're treating the whole person.
I try.
Appreciate that
Yeah.
for sure.
No, I like to get to know my patients. I get to know them as well as I can, and we spend a lot of time together. And it's very, as I said in my intro, you said in my intro, it's very rewarding, because I do get into every aspect of her health and leave no stone unturned, if you will.
I love it. I love
Yeah.
it.
Well, this has been amazing, Dr.
This has been
Hatfield.
more
This
than
has been
amazing.
so, yeah, it's just been so insightful. And you shared so much information, from just talking about the different phases of menopause to talking about the hormones, what the hormones do, what happens when when they start declining, like how can we help ourselves with managing them, and then some other things that we can do. I mean, I think you've just shared so much knowledge and information and gems that's, people, you would think women would have learned this somewhere, because we all are going to go through these stages. There's no woman, I mean, if obviously they live long enough, right, is going to miss menopause. And so this has been wonderful, like just such a wonderful discussion. So thank you so much.
Thank
Are
you.
there any final thoughts or anything else you wanted to share with us as we wind down the conversation?
I think the main thing to take away is just for women to know that if they're experiencing symptoms and they're in that age group, it probably is perimenopause, and just be curious and don't give up. As you said, advocate for yourself and find someone who can help you. Don't settle for being told that you need an antidepressant or a sleeping pill, when really the root cause of the issue is the hormonal decline. Try that first. I'm not saying that women shouldn't use antidepressants or sleeping pills, because sometimes they're needed, but I would say try to get your hormones optimized first, and maybe you will find that you don't need those things. And just advocate for yourself and do the best you can to get to that best version of you, because she's in there.
Love that. Carolyn, you have any final thoughts or anything you want to add, or any additional questions for Dr. Hatfield?
Yeah, I just appreciate the forum, that the four of us sitting here and discussing
so
things that so many women, even today, have no idea of what's happening within their own bodies. And it's so important that we have doctors and advocates like Dr. Hatfield, who are willing to come on these platforms and talk about it, so that we can get the information to people. And all of us are learning something too as we sit here and have our conversation. It's an important topic, and as you said, Kamisha, it's half the world's population if we live long enough. So it's time for us to live with the vitality that we deserve through these years. We've earned it.
And as we say, keep blooming, ladies, at the center table.
So much,
You like
guys.
You like how I added that, Carolyn?
I love that. That was awesome.